right. Hi, everybody. My name is Jigna. I think I've worked with many of you. And if I haven't, then I hope I'll get a chance to work with the rest of you soon. So today's presentation, I'm basically going to go over four different ED presentations with visual complaints. The goal of this presentation is basically to kind of help guide you through the management when these patients present with visual complaints and when you should consider neurological involvement and possible even consult in the ER and further management. Let's get started. All right, so the first scenario we have is a 15-year-old female who's presenting to the ER. She's complaining of a headache and progressive blurry vision that's been going on for about a week. Her vitals in the ER, she's afebrile, her heart rate's 91. Her respiratory rate is 18. Her blood pressure is 124/81. On physical exam, what's pertinent that you find is that she has mild bilateral photophobia that's noted. Her vision in her right eye is 20 out of 40, and her vision in her left eye is also 20 out of 40. But aside from this, the rest of your physical exam is benign, and there's nothing else that you really find. So what are some of the differentials that you guys would think about?
Pseudotumor cerebri.
Yeah, pseudotumor cerebri. Yeah. All right, so we're going to talk about pseudotumor cerebri. So it's also known as idiopathic intracranial hypertension. This is the diagnosis of exclusion. It's a clinical syndrome. It basically what it's defined as is signs and symptoms of increased intracranial pressure. And these signs and symptoms can present as headache, loss of vision or vision changes, which can be transient. They can also present or complain of tinnitus and as well. Along with these signs and symptoms, they should also have elevated intracranial pressure, but with normal CSF. They should have normal mental status, and there should be no other identifiable cause on neuroimaging for their symptoms. The prevalence is 1 to 2 in every 100,000, with the higher incidence in women, usually in the age of 15 to 44, although it can happen in the pediatric population. You can see it in teenagers and children as young as even 12 that I've seen. There's no precise etiology, but there are certain risk factors that are associated with pseudotumor cerebri. There's also some theories that have been mentioned behind it. Some of them have been like venous outflow abnormalities that cause increased resistance, altered sodium and water retention, also obesity related with increased pressure, and altered vitamin A metabolism. So some of the risk factors include women, obese women of childbearing age, a history of recent weight gain, hypervitaminosis A. If they have Lyme disease or hyperthyroidism, you also want to consider this. PCOS is common, and there's also certain medications that should always be in the top of your mind that you should think about that can cause this. And those medications are growth hormones, tetracycline. So if anybody has been started on antibiotics recently, if they're on OCPs, if they're on a steroid treatment, cyclosporin, lithium, and also certain sulfa medications can cause this. There's also certain conditions that have been associated with it, as such as like a mild ear infection, if somebody presents with a head injury, or even cerebral venous sinus thrombosis. Usually these patients usually present with a headache, and it is the most common symptom. It can often be subacute and progressive, usually over days to weeks. They can also present with visual disturbances, some of which could be diplopia. They may have some strabismus, they may complain of transient vision loss or even blurry vision. Like I mentioned before, they may also complain of tinnitus, photophobia, phonophobia, nausea, and vomiting, and they may also have some retrobulbar pain. In infants, this will be like a little bit more difficult to pick up, obviously, because they're not able to tell you what's going on. So they may just present with irritability or lethargy or sleep or behavioral disturbances. So it's really important that you do a very thorough like physical exam and take a very good history on these patients. On physical exam, your exam will generally be benign, but if you do an ocular exam, you may see some prominent changes. You will see papilledema. Usually it's bilateral. They may also complain of some visual field loss. They may also have a sixth nerve or a fourth nerve cranial palsy, so they may be unable to like adduct the eye. The rest of the neural exam is generally non-focal, like I mentioned. Other complaints that they may have is maybe some neck pain or nuchal rigidity, which may complicate your diagnosis with meningitis. So this is why it's important just to ask like further history if they do have these sort of complaints. So in a patient that you're suspecting pseudotumor cerebri, what sort of imaging would you guys want to do?
Ocular focus.
Ocular focus. Yes, I think that's a great thing to start off with, and that would probably be the first thing that I would do. So once you've done that, you see some papilledema. What other imaging do you think you would need? Do you want to do a CT, an MRI? What would be the indication? I'll go on. All right. So increase in your intracranial pressure should definitely be suspected with a headache and then the finding of papilledema that you may see on your ocular exam. You should get urgent like neuroimaging just to exclude any sort of secondary cause of this. An MRI with contrast and MRV is the preferred imaging to test and assess for any sort of intracranial mass. And you should probably consider MRV as well too to look for any sort of thrombosis that could be causing this. A CT scan you can do if an MRI is unavailable or if it's contraindicated, such as if the patient has like foreign bodies or metal clips, if they're claustrophobic or if they're very obese as well and would not be able to get the MRI. With pseudotumor cerebri, there should be no ventriculomegaly or any other abnormality that you should really see on neuroimaging. Okay, so let's say you've gotten your imaging done on this patient. The imaging doesn't show any sort of other abnormality, no mass, no thromboses. Would you guys want to do an LP on this patient? Yes.
Yes.
Why would you
Yes.
do it?
Because you want to relieve the pressure. Like, isn't that part of the management?
Yeah. Yeah. So this is like when you like what kind of want to decide is it an LP like an emergency? Is it something that you need that needs to be done in the ER versus is it something that needs to be done or that could be done like inpatiently? And I think this all also like depends on like the severity of symptoms. Um, LP though is the initial element and like is one of the elements in the diagnosis of increased intracranial hypertension. So if the neuroimaging does not reveal any sort of structural etiology behind the intracranial hypertension, then an LP should be performed and you must document an opening pressure. The CSF should also be sent for analysis to exclude any sort of other conditions. To get accurate pressure recordings, it's really important that you have the patient be relaxed and lying like in the lateral decubitus position. Other positions such as like prone or sitting position can give you like falsely elevated readings, as can like anxiety and certain sedating medications. So you really want to make sure that the patient's like generally really comfortable and in the correct position when you do the LP and obtain the opening pressure. Intracranial hypertension is defined as a value of more than 18 centimeters of water in children less than 8 years of age and more than 20 centimeters of water in children greater than 8 years of age. So less than 8 years, it's basically greater than 18. Greater than 8 years, it's greater than 20. So you have about like 2 centimeters to like a difference in the two. And then the CSF, like I said, should be sent for analysis for cell count, differential glucose, and protein, just to rule out other abnormalities. When would you consider a consultation for neurology or ophthalmology? When and why? And is this something that you would do in the ED? Okay, so an ophthalmology evaluation is required to document the severity of the optic nerve involvement and to monitor their motor or their response to treatment once it is started. So it's really important that you do get a consultation from ophthalmology just so they can do a full neurological exam and exclude any other of their optic abnormalities. You should probably, and they are basically going to be doing a complete ocular exam and going to be documenting like any sort of visual field testing that they do. They're going to be doing a dilated fundus exam and also like optic nerve photographs, which is important for them to do. A neural consultation, this is something that you don't have to necessarily do in the ED, but it's probably a good idea to do, especially if you're also like considering an LP and if there's a chance that this patient might need like a large volume drainage. So it might be good to like get their recommendations, on how much volume should be drained, what you should be titrating it to, and just to get like further recommendations. So like I said, the diagnosis is a diagnosis of exclusion. The patients will present with headache and papilledema. There should be no secondary cause on neuroimaging, and they should have an increased opening pressure with a normal CSF composition on LP. You can also do routine lab tests to rule out any other causes for this condition. So the management for this patient, so all patients that come into the ED, obviously you want to initially stabilize them and look at their ABs and Cs. These patients if they have significantly increased intracranial pressure, it can lead to Cushing's triad. So you really want to keep that in mind. Look out for any sort of hypertension, bradycardia. Irregular respiration is usually like a later sign. So just keep this in mind. The goal of the treatment is basically to treat the symptoms and preserve their vision. You want to make sure you discontinue any sort of medications that may be causing this, such as tetracyclines, OCPs, etc. You want to treat their pain with any sort of analgesia. You can do NSAIDs, Tylenol, or even morphine at that time. Patients may need a large volume CSF drainage, like I said, if their symptoms are pretty severe, if their pressure is more than 30 centimeters of water. The amount of drainage that is usually done so what I found from my reading is 0.5 ml per kg that you usually drain, or you can titrate it to a pressure of 12 to 15 centimeters of water. And this is why it's probably a good idea to consult neuro ahead of time, just in case you are going to be doing like a large volume drainage. It might be good to have their involvement. You can also, other treatment options also are diuretics or volume modulating medications, such as acetylcholine or furosemide, which generally has a better side effect profile than acetylcholine. Steroid use is generally like controversial. If you're considering starting steroids on this patient, you definitely should talk to neurology before. And then if the symptoms are very, very severe, the patient may need surgical involvement and may need lumboperitoneal shunting or even an optic nerve sheath penetration if it's severe. So the disposition for these patients, so patients with an intractable headache or a compromise requiring possible surgery, if the headache is very severe, these patients should definitely be admitted to the hospital. Their discharge criteria is basically improvement of symptoms or resolution of symptoms. any of these patients, if they're discharged, they need to have follow up with ophthalmology and neurology, like outpatient, just to monitor their symptoms and their progression. But they definitely should have if they're admitted, they should have a consultation to ophthalmology and neurology at least while they're in hospital. Any questions before we move on? Okay. So we're going to go on to our next case now. Our next scenario, we have a 19-year-old female in the ER with complaints of pain with eye movement and progressive blurry vision for the past 2 days. Her vitals are generally normal. She's afebrile, heart rate, respiratory rate, blood pressure, and oxygen saturation are within normal limits. On exam, what you find pertinent is pain with any extraocular movement of the left eye. Her vision is 20 out of 20 in her right eye. It's 20 out of 80 in her left eye. And she's also complaining of some loss of color vision in the left eye. What are some differentials that you guys would think about or that would pop into your head? So she's complaining of blurry vision, pain with.
Tobias said MS.
Sorry?
Tobias said MS in the chat.
Oh, MS, yes. Wait, Tobias. So yes, MS is definitely is something you should consider, and optic neuritis, more specifically in this patient. So optic neuritis is an inflammatory demyelinating condition of the optic nerve, and it's highly associated with MS. Usually, this is a presenting feature in 15 to 20% of patients where they come in with visual complaints. There's a predominance in female and Caucasian population, and also in the ages of 20 to 40, although it can occur in children. It's more prevalent in populations that are located in higher altitudes. There can be many causes for this. It can be idiopathic, but MS is probably the one that's most highly associated with this. It can also occur, there's been cases of this occurring in post-childhood, like after vaccines that children get. It can be viral induced, such as measles, mumps, rubella, varicella induced. Also EBV can cause this. Syphilis, tuberculosis, certain vasculitis can also cause this as well too. So the way they usually present is present acute with usually monoocular vision loss, and it usually occurs over a span of days, but it can occur over hours as well too. Bilateral presentation is more common in children from 12 to 15 years of age, although unilateral is the most common. And in certain parts of the world, it's a little bit more common to have this presentation, such as South Africa, Korea, and Singapore. The patients may also present with loss of color vision, which is out of proportion to the loss of their visual acuity. They may present of a retroorbital headache, pain with extraocular movement, something that they may also complain of, something they're not going to tell you. It's called a Pulfric effect. But what it is specifically, if you can imagine like a pen swinging side to side, they will they will see it as it like coming towards them in an elliptical fashion. So they'll basically feel as if the object is coming closer to them, even though it's not, and it's staying that same distance away from them. They may also complain or have like an afferent pupillary defect. So their direct response to light in the affected eye will be more sluggish compared to the other eye, to the unaffected eye. They may also complain of some flickering or flashes of light with any sort of eye movement. So for these patients, would you want to consult neurology or ophthalmology in the ER? Yes, no. When would you consider it? So these patients, so you would want to consult ophthalmology and neurology, and it's because you want to make sure that the treatment that you're doing is focused on the underlying cause of this and on MS, if that's your main diagnosis. A full ophthalmological exam is essential to help differentiate from typical versus atypical causes of optic neuritis. These patients will generally also have like normal intraocular pressures and a normal slit lamp exam with no evidence of uveitis as the cause. So the clinical diagnosis is based upon history and it is a clinical diagnosis based upon history and exam findings of unilateral painful loss of vision in an adult younger than usually 40 to 50 years of age. Like I said, it's essential to do a full ophthalmological exam, which is why you should consult ophtho in the ER. An MRI with contrast can help you confirm the diagnosis, but in most cases, it can also provide like some prognostic information. An LP is generally not essential in these cases. Unless you're considering like atypical causes, or if you're considering like a bacterial cause. If a patient does have bilateral presentation, or bilateral optic involvement, they're complaining of bilateral vision loss, and their age is less than 15 years of age, or like I said, you're considering an infection, then you should do an LP. Otherwise, it's not generally necessary. If you do an optic ultrasound, you may see some papillitis or papilledema. So you'll see some swelling of the optic disc or edema. You'll also see increased optic nerve sheath diameter, which is usually greater than 5 millimeters. And this is measured, so 3 millimeters behind the globe on ultrasound. And that's where you measure the diameter of the optic nerve. You may also want to consider doing some basic labs and also syphilis if that's something you're considering as a cause. Okay, so there's no clinical trial data that's available to help guide the treatment of children with optic neuritis. You generally want to treat their pain, with any sort of like NSAIDs, or if they need morphine. You want to consult a neurology and ophthalmology, like I said. These patients generally may need intravenous corticosteroids, and this is done in consultation with the neurology team. And the reason for IV corticosteroids is because there has been some evidence that shows that this treatment can delay the onset of MS and also hasten visual recovery. Oral steroids are generally not used. But in rare circumstances, I guess where your IV steroids are not available, they do suggest that you can use high dose oral methylpred. 500 milligrams is the max that they have written. IV methylprednisone is suggested in children and adults with severe debilitating vision loss or 2 or more white matter lesions that have been seen on MRI. And like I said, this is basically to help hasten the recovery and delay the onset of MS, especially in our younger kiddos. So the disposition for these patients, so if they have findings of optic neuritis, these patients should be admitted for IV steroids. They're going to need IV steroids for weeks, which can be given at home, but they do need to initially be started in the hospital, and they would need to be admitted at least to the hospital to, get home health aid and everything set up so they can continue to receive this treatment over the span of weeks. Any questions? All right, so we have a 3-year-old male presenting to the ER with right eye redness and blurry vision for 1 day after being hit in the eye with a toy. His temperature, he's afebrile, his heart rate, respiratory rate, blood pressure within normal limits. On physical exam, you notice an injected right conjunctiva. His extraocular movements are intact. His left eye, you don't notice any abnormalities there. He does have some sensitivity to light. He's closing his eyes on examination when you're putting a light there. You're unable to assess any sort of vision because of poor cooperation. What are some of the differentials that you guys are thinking of? Yep, traumatic iritis, yes. So this patient did have like trauma to the eye. So traumatic iritis is definitely something you should think about. You should also think about any sort of foreign body that could be lodged in the eye, abrasion, laceration, and globe rupture, which is something that you would be able to see as well. So this one is traumatic iritis. So it's usually caused by blunt trauma, which results in contusion and spasm of the ciliary body and the iris. It can occur in any sort of traumatic injury to the eye. The presentation is usually delayed after the traumatic event. The presentation can occur even as up to 3 days after the trauma. So they can complain of an eye injury, 2, 3 days prior, and now they're having this eye redness. Now they're having some photophobia, and they're presenting. So it can be a delayed presentation. So keep that in mind. These patients generally present with eye pain, tearing. They may have some ciliary flush that you may see, such as in this patient. They'll complain of photophobia. They'll have decreased visual acuity or blurry vision. They may see some floaters. They may have a sluggishly reactive pupil in the affected eye. In severe cases, you may also see a hypopyon, which is basically a leukocyte exudate that's collected usually in the anterior chamber of the eye. And then some complications just to think about is increased intraocular pressure in these patients as well. So these patients generally, you wouldn't really need neurology in the ER unless you're concerned for a severe mechanism of traumatic injury in the eye that may be extending beyond the eye. You may consider ophthalmology involvement if you're concerned for increased intraocular pressures and you want to get a proper full neurological exam. If there's a severe mechanism of injury, you're really unable to open the eye and fully examine it. And then also later on down the line, if you will be considering steroids or not, this would be a good reason to consult them prior to starting any sort of topical eye steroids. So for these patients, it's really important to do careful triage because their eyes are they're located near their intracranial spaces, the C-spine and the airway. They could have life-threatening injuries, like I said, that extend beyond the eye. So it's always important to start with your ABCs. This is a presumptive diagnosis until you do a slit lamp examination, which would be done with ophthalmology. And what they would see is the presence of some inflammatory cells and an exudative flare, which is not something that we would do, but it's something that they would do on their exam. A corneal abrasion should be ruled out in any sort of trauma to the eye. So you should do a fluorescein staining just to make sure that there is not any sort of abrasion in the eye. And then they should be given analgesia for their eye because it can be quite painful. It'll also be really difficult to examine their eye. So it's really important that you provide analgesia to the eye before you closely examine it. Cycloplegics can be used. They're usually used to paralyze the ciliary body, which basically results in a reactive and dilated pupil. It can help prevent the formation of synectae and the progression of the flare and the ciliary spasm, which can cause pain. Certain cycloplegics that you can use is homotriptine, cyclopentolate, and also scopolamine drops. Topical steroids may be indicated, but you have to always rule out an infection first before you start the patient on any sort of topical steroids. This should be discussed with the ophthalmology team before you start any sort of steroid treatment. These patients generally, unless there is a very severe mechanism of injury, you're concerned for injury extending beyond the eye, these patients will generally be discharged home, but they should have a close follow-up with ophthalmology in 24 to 48 hours, just to follow to see how they're doing and to make sure that their symptoms are not progressing. They can follow up a little bit later in 5 to 7 days. It is acceptable, if their symptoms were not very severe, but you can decide this based on a case-by-case basis. Any questions about traumatic iritis? It's a pretty straightforward diagnosis. All right, let's go on to the next one. All right, so we have a 16-year-old male with JIA who's presenting to the ER with complaints of blurry vision. He's also seeing flashes of light for the past 3 days. On exam, he's afebrile, his heart rate's 114, his respiratory rate's 18, his blood pressure is 125/85. On exam, you notice an injected left conjunctiva. He complains of pain with extraocular movement of the left eye. He does complain of some sensitivity to light. His vision is normal in his right eye, but in his left eye, it's 20/60. What are some differentials that you guys would think about at this point? Orbital cellulitis. Okay. Anterior uveitis. Yeah, so I was getting at uveitis here. So uveitis, we just talked about traumatic iritis, which is a type of uveitis. Uveitis is more of a broader diagnosis. It's caused by inflammation of the iris, the ciliary body, or the choroid. You can further divide this into anterior and posterior uveitis. And it's important to know this because the treatment depends on whether it's anterior or posterior. Anterior uveitis is inflammation of the iris or the ciliary body, which can be called iritis or ciliitis, and posterior uveitis is inflammation of the choroid. Causes can be, and there can be inflammatory causes that can be associated with HLA-B27. There can also be environmental causes such as trauma, like we mentioned, traumatic iritis or foreign body. There can also be infectious causes that can cause uveitis, such as TB, Lyme disease, syphilis, adenovirus. Also, patients that have IBD, you always want to keep uveitis in the back of your mind. Complications that you can get from uveitis can be cataracts. They can also get glaucoma or even retinal detachment. So the presentation is a little bit different depending on whether it's anterior versus posterior uveitis. In anterior uveitis, they'll usually present with sudden red, painful eye. They'll complain with pain with any sort of eye movement, and this is due to the ciliary muscle spasm, which irritates the cranial nerve 5, and which can also cause photophobia. They may have a ciliary flush as well, and marked injection of the limbus. Typically, they'll have small and poorly reactive pupil in the affective eye as well too. In posterior uveitis, they may complain of floaters, some vision changes. Generally, this does not cause any sort of redness to the eye or any sort of significant pain. They may also complain of some blind spots or flashing in posterior uveitis. And then in severe cases, you may see like the hypopyon, like I mentioned, which is leukocyte exudate that you'll see in the anterior chamber. So in these cases, you definitely want to think about like ophtho and neuro involvement. You may want to consider ophtho just to get a full ophtho exam done and to see like exactly where these symptoms are coming from. If it's anterior or posterior, they would have to do a slit lamp exam to correctly diagnose uveitis. You may want to consider neurology if you're considering like infectious causes that extend beyond the eye, like if you're considering like an encephalitis due to like due to HSV, or if you're considering RPR or syphilis, sorry. So the management for these patients is usually like a clinical assessment that you start with. You want to ask you want to do specific physical exam and look for certain findings that may uncover the cause of why they may be having this uveitis, such as patients with IBD. They may complain of GI symptoms or joint pain. Patients with HLA-B27, they may complain of some sort of joint or back sort of pain. Patients with herpes, you may see some skin vesicles somewhere on their body, which may be the leading cause of this uveitis. If you're considering sarcoidosis or tuberculosis as a cause of the uveitis, you may want to consider a chest X-ray. If an infection is the underlying cause, you want to treat the infection. If it's a non-infectious cause, then the treatment depends on the location of the uveitis, whether it's anterior versus if it's posterior. If it's anterior uveitis, generally they use topical steroids, and this is usually done in consultation with ophthalmology, which is why it's important to speak with them beforehand, especially if you're considering starting them on prednisone eye drops. They also may need some medratics or some sympathometrics just to dilate the iris and prevent formation of further synectae. Like I mentioned before, you can use cyclopentolate, homotriptine. You can also use like phenylephrine eye drops. They also may need some cycloplegics just to help relieve the severity of the eye pain that they have. You can use cyclopentolate or scopolamine for this. For posterior uveitis, generally it's not responsive to any sort of a topical treatment, which makes sense because it's in the back of the eye. For these patients, you'd want to speak with ophthalmology because they're the ones who are going to tell you what the further management for this patient is, whether you want to continue to observe them and watch for progression of the symptoms, or if they're candidate for intraocular steroid injection, which is something that they would be doing. So the disposition for these patients. So generally, the patients can be discharged home with an urgent ophthalmology follow-up in 24 to 48 hours. But in some cases, you may want to admit for observation. And this basically just depends on the severity of their symptoms, or if this is a recommendation that's based or that's given to you per the ophthalmology team. But the majority of these patients can generally go home. Any questions? So I have a few board review questions that we can do next. So let's go through that. Does anybody want to volunteer to read the first question?
14-year-old moderately obese female presents with a 4-day history of worsening headache and dizziness. She has no prior history of headaches. She is currently taking minocycline for treatment of acne. She denies sexual activity and has had normal, regular periods. On exam, she is in moderate distress, complaining of severe 8 out of 10 head pain. Her blood pressure is 138/85, heart rate 90, respiratory rate 50, and temperature 37.5. Her optic discs are difficult to evaluate, and her cranial nerves are normal, as are her DTRs and motor examination. She has a normal gait and a negative Romberg sign. After initial evaluation and treatment in the ED, which of the following medications will most likely benefit this patient as an outpatient? A, acyclovir, B, sumatriptan, C, naproxen, D, oxycodone, or E, acetazolamide.
Thank you, Nick. All right, so what do you guys think is going on with this patient? E. Thanks, Kelsey. What do you think is the diagnosis for this patient? What do you think
is this IIH that we're looking at?
Yeah. So this patient most likely does have intracranial hypertension, pseudotumor cerebri. What do you think, based off the history, may be contributing to this? Is there anything in the question stem that points to it?
She could have like hypervitaminosis A. I don't know if minoxidil would cause that, but I know a lot of like the acne medications can, like Accutane.
Yeah. So tetracyclines is a risk factor, right? Like certain tetracyclines can cause increased intracranial or idiopathic intracranial hypertension. So I think that's why they put it in there, just to help you guys like figure out the diagnoses from there. So this patient does have pseudotumor cerebri. So the treatment of choice for outpatient would be acetazolamide. So you're correct, Kelsey. So if the patient is stable for discharge, acetazolamide should be prescribed for outpatient use with close follow-up, especially for any sort of visual changes. Acyclovir is not indicated in this patient unless there's evidence of like a herpes encephalitis, which would require admission. Sumatriptan is indicated for migraine headaches and not for pseudotumor cerebri. Naproxen and oxycodone is just like an adjunct for analgesia. It's not going to help with the symptoms of the pseudotumor cerebri. Just keep in mind that an imaging study should be done to rule out any sort of intracranial tumor or bleeding, followed by an LP to assess for increased intracranial pressure. And this is most prudent, and it should be done, be a part of your ED management. Any questions about this question before we move on? Anybody want to volunteer the next question? I can read it. So there's
A
7-year-old
seven-year-old male is brought to the ER after developing left eye pain and blurred vision after he and his friends were hitting rocks with a hammer. The injury occurred approximately 2 hours ago, and the pain has been worsening. He states that his eye hurts and he has been unable to see clearly with that eye since the injury. On physical exam, the boy appears uncomfortable as rubbing his left eye. There is epiphoria and conjunctival injection. His visual acuity is 20/20 in the right eye and 20/50 in the left eye. His extraocular movements are intact and his pupils are equal, round, and reactive to light. Of the following, the most appropriate next step in the treatment of this patient is to A, administer topical anesthetic, B, evert the left eyelid, C, measure the intraocular pressure, or D, perform a fluorescein exam.
So what do you guys think? What are you concerned for in this patient? I'll give you guys some time to think about it. What do you think is going on?
I think the most concerning thing probably is a foreign body in
Yeah.
the eye.
So which answer choice do you think would be the most appropriate? Most
Like-
appropriate next step.
Oh, I was gonna say a lot of these seem like an appropriate thing to do. I would probably start with an anesthetic so that you could do the rest of the things.
Yeah, great, Kelsey. Yeah, so you are concerned, we're concerned for an eye injury secondary to foreign body in his eye. It's really important that you do a very proper eye exam on this patient. However, if the patient's in pain, he's not going to open his eye. He's not going to let you do a complete optic evaluation. So it's really important that you administer the appropriate anesthetic first before you try to do an eye evaluation. So administration of topical ophthalmic anesthetic should be performed first to make the patient more comfortable and to facilitate the remainder of the examination. Lid eversion, you should do this just to make sure that there's no foreign body that's trapped under the eye. But however, this should all come after you administer the topical anesthetic. You should do the fluorescein testing to look for any sort of corneal abrasion that may be caused by a foreign body. And then tonometry is basically to look for any sort of acute angle closure glaucoma, and this if it's suspected in this patient, or to obtain any sort of baseline measurement in the setting of any blunt eye trauma. It may be indicated in our patient with a possible corneal abrasion, but it is contraindicated as it can worsen any sort of existing corneal injury. So before doing any of this, you'd probably want to speak with ophthalmology, and they'll be the ones to do any sort of testing for intraocular pressure. But the first thing that you would want to do is administer the topical anesthetic. So whenever you guys are doing these board questions, there's going to be a lot of answer choices that seem like the right choice. So always just go back to your question and see what they're asking for. They're mostly going to be asking for the initial treatment, the most important first treatment. So just always go back to the stem of the question if you ever get confused. Any questions about this?
Yeah, my only comment is just make sure he hasn't perforated his globe.
Right.
It looks like that, then you don't do anything except cover it and get ophthalmology stat.
Absolutely. Yeah. I think we finished a little bit earlier today. These are my preferences. Any questions?